Yeah, I think we are live now. I think I had the wrong key before. And just getting the confirmation. Just waiting for the confirmation. You should be live, but yes,
Okay.
we are live.
All right.
Okay, so let's see. Good afternoon, everyone. This is United Medical ACO. My name is Kemal Erkan. I'm here with Donna Gunkel today. Tanner is off. This is his second week in a row, but he'll be back next week. But in the meantime, we have some housekeeping items that we wanted to actually address. And Donna, as our one of our directors on the clinical integration, she's going to be my dialogue partner, that I'm going to call her. So, Donna, if you would like to please introduce yourself, and then we can start the presentation.
Absolutely. Good afternoon, everyone. Yes, I am Donna Gunkel, the Director of Clinical Integration. So I am over our care coordination and nurse teams, as well as our wellness programs, which include behavioral health and diabetes nutrition.
So, and I just need to send, okay, so I got some updates from people saying that we were live. Thank you for that. And just to make sure that our provider groups also is aware of this. So let me just send. We have two broadcasting lists, so I'm just doing that right now. So this is. Okay, now everyone should know what's going on. Okay, and I'm going to ask my team today. Actually, I'm in the home office, but hopefully, as they always do, my office team will be letting us know if we have any technical issues, but we shouldn't. We are going to give you some updates on vaccination on COVID. So let me actually start with that first. Let's see, it's so we are going to utilize this is our this year. This is the 24th session. So except maybe 3 weeks or maybe 4, we have done this almost every week. After the COVID numbers, some workflow issues in healthcare that I believe most people don't really either understand or don't know. And we are also being challenged by these issues. And I thought Donna would be the great person to have this dialogue, because we are actually discussing this every day, but we don't really know what would be the best solution, or we do need other people's help, other organizations' help to solve these problems. From United Medical standpoint, we are a medical billing electronic medical record company, where pretty much it's a turnkey solution. The fancier name would be revenue cycle management for medical billing, but now the fanciest name would be the accountable care organization, which we do the most population health management in Delaware mainly, and we are responsible for more than 115,000 lives. So now, just to give you guys the vaccine update, as we were worried about what was happening with the total numbers, is the number of total doses being administered every day is getting lower and lower and lower. So that's down to 518. So Donna, this is something that we were addressing in our providers meetings, and this number used to be 3.2 million, now down to 518. The goal of 75% is the key, and getting to that level is it's getting challenging every day. So now we are about 9 months away from that time. So if you remember my projections, even when they were being more optimistic with the, July, and we were saying, look, if the numbers are not staying the same, we won't get to that level. And now, maybe 2 months ago, we were saying it was going to be December, but with the new numbers, December is not going to be even possible.
Right. It looks like it's going to be about the end of the first quarter of next year at this rate. Right?
Correct. So, but now, why do you think people are not getting the? I mean, we have enough vaccines. We are donating them to other countries these days. Why do you think they're not getting them?
Well, I think some people still don't feel that it's gone through the proper process. And with things opening back up, they feel it's no longer necessary for them to get it, even though people are still contracting COVID. I think what may help us is some of the schools and colleges that are looking to make this a mandate, when students return in the fall. I think that will potentially help push up some of the numbers. Hopefully we don't see a large spike in our cases in the US. I think that might be the only other thing that would potentially encourage people to get it when they see that it's still, an issue out there.
So now you from the clinical side, you have a nurse background. So something that actually is being tested at this level. So like we know that this is safe because no other medication or vaccination has this much statistics that we can rely on, right? So from that point, people really shouldn't have any other concerns anymore. So one of the, when I was going through some of the prep for today, like right now in Texas, 95% of the people who die with COVID-related stuff are from the unvaccinated group of people. So I'm going to actually just share that.
And I think one of the things when you say about it being safe is, some people don't realize that the vaccine, at least part of the base of that vaccine, was the same components that were used in other vaccines, and that the vaccine went through the same steps, the same process. It was just on an expedited, in an expedited manner, because of course, the government made sure that there was funding for that, whereas some of the others may have a longer delay due to lack of funding and other reasons.
So since February, about 9,000 people died in Texas, apparently. So that's 95. I'm sorry, I said 95. It was my mistake. It was 99.5% of the people are from the unvaccinated. So that's pretty crazy. So now I'm hoping that we can actually, we can maybe increase the awareness. And I know your team has done a lot for Delaware with the United Medical, under the United Medical umbrella, but I think there's still more can be done. But I think time will show what else can be done. So let's see, there are, so this is from the Delaware standpoint, we are at 57.4%. I think we did okay, a little bit better than, as a small state, we did better overall. Not like we are in the top 10 or anything, but I think we were able to manage it better in overall. So now, of course, the issue is the variant, and the Delta variant is one of the biggest issues that we have right now. So this is a big concern. Now, Donna, anything that you want to add in terms of how this how it's progressing with the virus, and why this is important for people? Even if you are vaccinated, we are still at risk because it's not 100% safe, right?
Right. I mean, nothing's ever 100%, but no vaccines are. I mean, we like to remind people or educate them that even with other vaccines for the measles and things like that, or the flu, it may not mean you don't get it. The goal is that if you do contract it, it would be a much milder case. So I think that's one thing that we always want to keep in mind. And like anything, there could be variants that are not responsive. But again, they continue to do the research and, determine if the vaccines will cover, other strains as well.
Sure. And I think this the speed, the spread, like how fast this is actually spreading is what's how we are able to differentiate this one from the others. And I think this is going to be something that we really need to better position ourselves, especially now we are almost end of July. So the flu season is coming back as every year it does come back. So we're hoping that this won't be a problem, which I mean, it is already a problem. And I think part of the reason that we do this event is to help the public to understand some of these things and hear them a little bit differently, maybe understand it better, because the issue is this. So what I'm hearing, one of the reasons that I'm actually really concerned is, so we actually shared these posts on our social media pages. And every once in a while I read the comments and it's unbelievable. There are a group of people who are haters and they really do put a lot of bad information out there. And when I read them, like sometimes like I have the admin access, I can ban the users. I ban like 10 of them, but I'm like, I can't just keep banning them. So there's so many of them. So when you see this many people, then you understand that social media does have a bigger responsibility how this information is being disseminated and who has access and what they actually is sharing. Do you get any information from the social media for these?
Well, I mean, I try to stay abreast of that. But again, I think like you talked about with misinformation, it is important to make sure that the sources that you're getting the information from is more of a source of truth. So making sure that you're looking at the source that it's coming from and not just believing everything you see out there, because sometimes people are putting their personal opinions versus factual information. So I think that's one of the key things that we need to keep in mind.
So I think there's like, I mean, from what I see, Donna, I think from the projection standpoint, winter is coming back. Winter is coming. So all we can do is better position ourselves and hitting certain numbers to make sure that the population is ready, public is ready. And if there's a new challenge, like no one wants to go back and close the businesses, and no one wants to go to the same painful process that we did. And you were part of United Medical's process with our employees, our families, our patients. And when things are just a little bit better, this doesn't mean that things are okay. So we just need to be proactive, right?
Yes, and I think one of the key things there is last year we learned, because we were still deep into the pandemic, that a lot more people got their flu shot, which was a good thing. Also, we were wearing masks. So I think for those that have compromised, immune systems, they were protecting themselves. People who weren't feeling well were protecting others. So I think that's one thing to keep in mind, regardless of where exactly we are with the pandemic, is those should be practices that we use more often. So if we're not feeling well and going out into public, we might want to consider wearing a mask if we're going to the grocery store or something. Also, if we have a loved one or ourselves, if we have a compromised immune system, is to also wear that mask, continue to wash our hands, use the hand sanitizer, use the wipes on carts and things of that nature. Those can be those proactive, preventive things that I think you're talking about, Kemal.
Yeah, at this point, like, it's more like protecting the people who are not vaccinated. It's not about people who already have, like myself, like I already had COVID early on, April. I got the first, I guess I was in the first batch as I was trying to protect everyone.
You were trying to be a leader out there.
Right. So then I got my 2 shots. So for me to get infected again, it's almost
Right.
impossible.
Right.
Now, if I'm here and taking time away from my business and I'm making this event and talking to public and telling people get vaccinated, we don't get paid for this, by the way. I don't know, Donna, if you get paid,
we do not.
But we don't.
We're doing this to educate the community.
In fact, there are some losers on social media that are posting some stupid stuff. So let me just tell you, this costs us money when we have to vaccinate people. From my business, from our business standpoint, we had to actually use our resources. Yes, government has given us the vaccines, but we use our own resources. So those days we couldn't see patients. So there is no financial return. So that's not what we are doing this for. This is totally social responsibility that we have. So if this is not clear, well, look, I mean, I don't mind if you want to go to some island and just hug each other all day long and don't do your vaccination and, just get sick and then, do that. That's your prerogative. You can do that. I cannot stop that. But if we are saying that we are going to go back to normal, because the other thing is that utilizing resources when we have only so many beds available, so many hospitals, so many facilities available, how are we utilizing these places, these resources? Yes, you are taking the risk on your behalf, but you are still risking other people's lives when you are not stopping it at a certain level. So getting to 75% is important. Now, I can only hear some people saying, well, what about, in England, they didn't get, they got the 75%, but they still have issues. That means there's still so much unknown in this. So when we are getting into this much unknown and still dealing with these problems, what we want to do is we want to get to that point ahead of time. We don't want to be in the middle of that unknown in January or February. And we have said this so many times and we are going to keep saying it, but I'm hoping that people, maybe every time they hear one of these things, they can actually learn and maybe they can understand that this is not about there is some Illuminati out there who's trying to get you vaccinated. No one has any interest in anyone's genes. I mean, you can keep it if that's what it is. Now, Donna, one of the main reasons today I asked you to join me is, let's forget the COVID for a second. So you and I, one of the reasons that you actually joined United Medical, is it 6 years old now?
Almost 6 years in October.
So the main reason was the clinical integration. We have accountable care organization. We run 6 different contracts with the value-based and so many different challenges that we learn because they're all different contracts, they're different population. The risk score, risk factor, risk adjustments, many people don't understand what these are. And then the cost and how that's associated with the risk of the patient. When we say risk, we think that the patient, just like if they have some really serious issues, they are risky versus it's all about the prediction. How much they spend a year before is going to predict what they are going to be. Of course, there's some demographics and other base stuff. So I have an idea, and then I just want to run this by you. So I'm gonna, our marketing team give me a couple of images. I'm gonna try to use them to see if that would work. So if it doesn't, then I'll try to explain. So this is kind of like I used this image before, I believe. So this is kind of the current setup we have, right? So we have our PCPs and specialists. And on the right side, we have the institutions. These institutions are hospitals, nursing homes, rehabs, and assisted living. Just like there are, of course, others. Now, so where we are struggling is managing high ED utilizers, patients who go to the ED on a regular basis. So this is, let me actually start using my drawings here. So when we have, let's say we take patient X here. So let's see if I can check that. So this patient, let's say we identify this patient as a high ED utilizer. So Donna, what's the high ED utilizer for us? What's the minimum, like they have to be for United Medical?
Sure. I mean, usually we look to see if they've been in the ER like 5 to 6 times within a 12-month period, and that would be like a rolling calendar year.
Sure.
And then, of course, we identify why. Are they going in for the same reason or for various reasons?
So now in this case, when we call them as high ED utilizers, so they go to the hospital by bypassing their PCPs.
Mm-hmm.
For the issues can be addressed by the PCP, but they rather go to the hospital. Now, our problem, or my idea is, well, the hospital sees the patient, let's say 6, 7 times. Now, I think Donna was being nice. That was giving our kind of standard number. So let me do this. What you see here, 2 different insurance groups on Medicaid. This is the first line item here is patient number 1, patient number 2, patient number 3. So on the second Medicaid group, patient number 1, patient number 2, patient number 3. These are in 2021. How many ED visits? Number of ED, emergency department visits. So now, this is one patient. I know if you are going to listen to this later on, I'm talking to the audience, so sometimes they're like, is that real? Is this real? 42 times this patient went to the ED. So Donna, your team actually called these people, so you can attest to this. 34 times, 24 times, and so on here. And then same thing here. So this from the Medicaid standpoint, this is one group, one managed care of the Medicaid, and this is the other one. And then I'm showing you real patient data. It's not an assumption. So now from here, let's go back to our diagram here. So when this patient from here goes there 42 times, all we are saying is, can the hospital take the ownership? So Donna, you and I, we met with the hospitals in the beginning, and then you know our positions on this one. But what I'm proposing is, if the patient is going to go to the ED 42 times, 22 times, 35 times, why don't we, these hospitals, they all have family medicine residency programs, right? Mm-hmm. So why don't we talk to the insurance companies and assign these patients PCP responsibility to the hospital. So then take us out of the picture. Now, people are going to say, why does this matter? Well, because we are not able to help these patients.
Because usually they're bypassing us to get to the ER, and then when we try to call them to get them to be seen, what we call a hospital follow-up appointment, usually they're unreachable or they refuse. to circle back to their PCP. So therefore, we don't know the patient now. Like typically we know the patient and we feel the best place for them to receive care, right? That's not emergent, is with the PCP because we know them best. And if the hospital is treating them 42 times or 22 times, clearly they have more information at this point than our practices do on the needs of that patient.
So, I mean, I think this has to be one of the focuses, one of the main issues that we have to focus on, because the other thing is that we are being penalized for these patients because hospitals are getting, each hospital for each ED visits, they get paid. So when the patient goes to Christiana Hospital 42 times, there are 42 different payments of the ED. Each ED visit is being paid. Now, when that happens that many times, then when it's paid, then when we are trying to actually manage these patients in AAA, which is the state of Delaware's model, AAA, increasing the quality, lowering the cost, and then making it accessible. How are we going to increase the quality and then when we are not able to get to these patients because they go to the ED and let's say the group of these patients, usually they have problems like acute problems or chronic problems, but they can be addressed in the outpatient setting, but they don't want to follow the rules of the offices. They'd rather just go to the ER. I mean, you guys would remember from the old sessions, we have patients who go there for medication refill. I mean, I know it sounds like a joke, but then what's even sadder is that medication refill is filled. So my main problem is I'm not taking this battle with the patient, I'm taking this battle with the hospital. What is hospital's accountability and responsibility? At what point hospital says, because they send us progress notes or the follow-up discharge instruction, transition of care documentation, right? None of your team gets them, and then we call the patient doesn't answer. So, but like when you have the patient in your hospital 40 times, wouldn't you want to just pick up the phone and then say, look, you are the primary care for this. This is what's happening. How can we actually help this patient? That never happens. Now, our initial meetings, we wanted to have the collaboration with each hospitals. And every time we wanted to set up something that was proactively engaging ED with the PCP offices, that was declined, except Nanticoke Hospital, if I'm not mistaken.
Yes, so, and we still have that with Nanticoke where when patients are actually inpatient, when they're inpatient, we coordinate to get them their hospital follow-up scheduled before they ever leave the hospital. So we coordinate with the discharge planners and they're handing the patient their follow-up appointment before they leave. We don't have the same setup with the ED, but we do get information from them directly the day after, the business day after they've been in the ER. And so we can also talk to them and coordinate those efforts to get the patient back.
So there is a direct connection between our office and Nanticoke, their communication when that happens. And that's not like some fax or interface, but that's real person.
Yes, they call. Right? They have their team call our team.
And we wanted to do that first with Christiana Hospital and then St. Francis, then both didn't happen.
Correct.
So
yeah, they said it couldn't happen real time.
Yeah, well, if it's not real time, then there's no value. So I mean, that's kind of like what we are dealing with. So then then it's coming to the like we are being responsible for something that we are not accountable. Well, we are being responsible for something that we are not able to control. Someone else is actually benefiting, hospital, someone else, aka hospital, is benefiting financially with no accountability. and the responsibility is being put on the PCP's offices. And then all we see is, well, the hospital did this, hospital's going to do this new integration. Well, no, we'll stop treating the acute problems, PCP-related problems in your ED, and we'll have a good progress in terms of the quality and the cost. So I mean, we can just start from there. But I thought, at least for these patients, I do want to start a process with each insurance, Donna. And this is kind of like our internal business meeting, actually. So we are just doing it in public. So I'm going to start the process, and I'm going to tell Blue Cross Health Option. I'm going to tell Mary Health. I'm going to say, here's your patient with 42 ED visits. Assign this to Christiana Hospital's family medicine. Assign this to St. Francis's family medicine. Because there's no reason for this patient to be on our list, because that's just nonsense. I mean, do you feel differently, or are we like going out of? Is it like crazy, or is it reasonable?
Sure, because I don't think that there are a lot of them. So I think we want to put it in perspective that we aren't talking. I mean, when we have thousands of patients with each of these insurances, we're not talking hundreds of patients, right? We're talking, you know, a very small percentage of the patients, because most of our patients,
who's responsible for a big cost, right? So
correct.
Very small, yeah.
Yeah, it's kind of, you know, that rule of thumb there. So yes, because I think those are the ones that we try. I mean, we use our own workflows and processes to try to streamline and be able to do what we're held accountable for from the quality, cost, and utilization perspective. But a lot of that's taken away from us between the patient and where they're going, you know, and not coming back to the PCP. So we understand there's certainly times that they need to be in the ER. Most of our insurance companies have provided us with documentation to hang in our practices for our patients to see that show that, right? They show the dollar signs, the 1, the 2, and then they show when should I go to each one of these facilities, I'm going to call it. So they'll have information about when should I, you know, what types of symptoms should I see my PCP for? If my PCP is not available and it's urgent, I should go to a walk-in and urgent care. And then what are the types of things that are considered emergent, and when should I go there? So actually the insurance companies are providing us with that level of detail for us to help educate our patient, their member, on this information.
I mean, in a simple word, like we as primary care offices in the accountable care organizations, we are fully accountable for what we do. But when patients are outside of our control, and you are correctly, as you correctly said, these patients is not a big population. It's not too many people, but it's a big cost group. So they are actually, I'm trying to remember the number from our prior presentation, but like 75% of the cost coming from 25% of the high ED utilizers, and then that's not a lot of patients. So 82 patients from one of the commercial insurances is responsible for 15% of our total cost, which is
out of thousands of patients. So you're talking less than 100. So it really is, you know, a small. I think that's just important for people to understand. We're not talking, you know, about the majority of the people. We're really talking about the outliers. Really, that's what they are. They're
exactly. Because and then they can actually, and I'm not saying this that we are penalizing hospitals either. They're benefiting from income, right? They make their fee for service, but maybe patient also can benefit from the service, because if they keep that internally, then
they have the communication that we don't have with them.
Yeah, so, exactly. So then,
sure, I totally agree, and we've talked to them, right? We've talked to the ED departments at most of those hospitals, and they've basically told us that they have that internal communication when patients are in their facility, because they're in the same EMR system. And so they have a way to communicate with their own practices in order to schedule the appointments that we're looking to schedule, but are unsuccessful in doing.
Absolutely. I think if we can initiate that for the rest of the year, if we can maybe get to that level where as of January 1, 2022, those patients can be receiving those services, I think that has to be happening, because the other problem many people, they don't really understand, because, well, again, let me actually just take a step back. When our performance in the value-based contracts, when people read them in the news, what they don't know is how we are being measured. So we are being measured based on our own numbers. So we are competing with our own numbers. For example, with Medicare, we are the least expensive ACO in the state of Delaware since the beginning. But in the first 2 or 3 years, we couldn't make the return because we couldn't beat our really low numbers. But some, very high expense ACO was able to reduce their numbers a little bit, and they were able to make a big return. So there's this like no kids left behind approach or mentality. So we don't want this to be understood wrong by other people. So, and then because we have to deal with this every year, how can we actually make it better? And then make sure that we don't lose these contract deals because of these types of unfair business practices. And I think this is something that needs to be addressed, and we are going to actually take care of that. And we'll start the communication with the insurance companies and the state of Delaware too, because this impacts our Medicaid population. Now, when we talk about this, many people who are listening, they may say, like, why do you think we care about? Well, we provide service for 115,000 people in Delaware. So that's 15% of the population. Well, that's a big deal from the service standpoint. And in order for us to be able to do this efficiently, some of our issues needs to be addressed. Now, we don't have the hospital label on us. We don't have the nonprofit label on us. So we are lean businesses. So whatever we do, we are accountable. We don't have any irresponsible budget items that we can just say, oh, we got a 10 million donation from some family, so we can spend money in the big lobbies in our buildings. We don't have that. So we have to be lean. That's why we care about these things, so we can actually focus on services, so we can keep our providers happy, so then we can provide the services for the population. Now, one of the biggest concerns is number of providers, number of physicians, availability, access to the providers in the state of Delaware. And from the cardiologist standpoint, your husband is one of the technicians in one of our practices in the cardiology practice. In Sussex County, there are not many cardiologists available. As the population is growing, especially elderly population is growing, and if you don't have enough cardiologists there, and if you don't do our jobs, and if you don't support our providers, then who's going to suffer is the patients, because there won't be any access. So this is all kind of connected to each other. So I hope that people are understanding and listening this from most objective point of view, and then try to see why we are actually making these things available for public. So we have another event today, our Bariatric Friday. Dr. Erkan is going to be with me at 1 p.m. It's going to be in 15 minutes. So we'll be back again next week. Tanner will be back. So I believe we have a couple of guests lined up, but I don't know if they're confirmed yet. But we are going to continue discussing on some of our items that we started. Donna, did you want to have any closing comments?
I would like to put one little plug in. So because we care about our patients and we're always looking to set up programs or improve programs, we have an accredited diabetes nutrition education program for our patients. We have 3 dietitians and we are looking to hire a 4th. But one of the things that we hear our patients tell us is that they would benefit from a support group for patients who have diabetes. So we will be starting that. Our first one will be held, thank you, on July 28th. So it will be the 4th Wednesday of every month. And we're going to have a specific topic. So any patients who have seen our dietitians and they have diabetes, we will be, and we have their email address, that's key. We will be sending them out an email with an invitation to pre-register and attend these sessions. So we feel it's one more way that we hear our patients and we try to meet them where they are and provide them the services that they're looking for. So our first topic is how to handle summer eating. People are going on vacations, barbecues, parties. So that will be our first topic, and we hope that we'll get many of our patients to attend that. So thank you. Sorry, a little off topic, but just wanted to get that.
No, that's I'm glad it was part of it. So actually, Donna, today is the day that we qualify for our YouTube channel now is able to make money. As we promised, any income that we make from the YouTube channel will go to the charity. Between YWCA and Brandywine Valley. I mean, we are in the beginning of it, so it's going to be very little in the beginning, but today we hit 1,000 subscribers. Bambi, one of our practice administrators at CRIAS, her mom actually hit it, and Donna, one of your nurses, she missed it with 1. So she was 1,001, and then Bambi's mom was 1,000. And we already hit the number of hours being watched. So I think my nephew was helping with that too. So, well, we thank you for supporting us. And again, our goal is not to make any, income from this for ourselves, but from the beginning, our goal was to see if we can actually generate enough income to put it back in charity, back in the community, and that's what we are going to do. Well, thank you for supporting us, and thank you for being with us. Donna, thank you for being with me today, and we'll see you in 15 minutes today, and then if you're not able to join the Bariatric Friday, then we'll see you next week. Thank you so much again.
Thank you.